Hi, and welcome. We are all representatives of the Franklin and Marshall College Public Health Program. Recently, we reached out to the community and asked what questions you have related to the current COVID-19 pandemic. What we're going to do in the next few minutes is take our time and respond to these questions in the best way that we're able to, based on information we have today, which is the 28th of April, 2020. My name is Janine Everett. I am the director of the Public Health Program. And if everyone.
I'm Jen Meyer, and I am an assistant professor in government and public health.
Go ahead. I am Harriet Oketch, an assistant professor of public health housed in the biology department.
I'm Emily Marshall. I'm assistant professor in sociology and public health.
Okay, so what we will do is direct each of your questions to a member of our faculty who will take some time to answer. First question is for Professor Meyer. Do you think we will see another pandemic of this scale in our lifetime?
Well, it's important to note that we've already witnessed other pandemics of this scale in most of our lifetimes. The current estimated COVID-19 death toll as of yesterday was just under 208,000 people. The death toll of the HIV/AIDS pandemic from 1981 to the present is between 25 to 35 million people. So we've clearly already living with other large-scale pandemics. COVID-19 is transmitted via respiratory droplets, which makes it more comparable to the 1918 Spanish flu pandemic. The Spanish flu pandemic infected 1 in 3 people and killed approximately 50 million people worldwide. So there's a lot of factors that would go into whether we would see another pandemic of this type and scale in our lifetime. It's very likely that we will observe other deadly respiratory illnesses develop. SARS in 2002 was more deadly than COVID-19 by most accounts, but also much less infectious. We don't really have much control over whether future respiratory illnesses develop, but we do have some control over whether they become a global pandemic. SARS had much less of a global impact, in part due to better surveillance, isolation of those who contracted it, and strict quarantine measures. We live in a much more interconnected world than we did in 1918 when the Spanish flu pandemic hit, which makes the spread of diseases more likely. But we also have more advanced hygiene, more advanced technology, and better research on public health preparedness to help stop an epidemic from becoming a global pandemic like we're seeing now. So what I would say is that whether or not we see another pandemic of this scale in our lifetime depends a lot on the lessons that policymakers take from COVID-19. There's a lot more that the United States and other countries can do in terms of public health preparedness, surveillance, and monitoring that would enable us to reduce the likelihood of enduring another pandemic of this scale.
Thank you. Does anybody have anything to add before we move on? No? Okay, great. Professor Marshall, someone asked about the effectiveness or efficacy of drinking hot drinks to try to prevent or control infection.
Thank you. So this, while not strictly a sociological question, is one example of something that we often see, which is people trading information or things they hope that they hope are true in times of uncertainty. So one of the things we want to do when we hear information like this is check against a trusted source. So our librarians are one way we can find trusted sources. Another thing we can do is go to some of the medical expertise to see what it says. People who use the scientific method to test theories about things like this use control groups to test whether there's an actual effect on things. And they have learned that hot liquids at temperatures that humans could drink cannot kill this virus. So temperatures of 158 degrees Fahrenheit can kill the virus. So if you're cooking food, it could kill a virus on the surface of the food, but that is too hot for humans to drink. And it is not the case that you can do that inside your body during some part of this process. So hot drinks can make you feel better when you have cold and flu symptoms, but they will not actually protect you from the virus. So again, look for trusted sources of information on things like this.
Awesome, great tips. Anybody have anything to add? Okay. All right, so this third question is for me. How long does the virus last on clothes and other surfaces? And how does a virus die off with a change in temperature and radiation from the sun? So that's a really good question. And we've started seeing a lot of information, some of it very well based in research and science, and some of it a little bit more gossipy and hearsay. The first thing is we're basing some of what we think we know about this novel coronavirus, that is the COVID-19 virus, on research that's been done about other coronaviruses in the past. This is not the first coronavirus that has existed. And so scientists, researchers have taken what they know about these prior ones and tried to parlay that into information about our current virus. At the same time, researchers are actively trying to learn more about this specific virus. What they have learned is that the potential for causing us harm does significantly go down. It goes down substantially as temperatures go up and as humidity rises. So in the wintertime, we tend to have lower humidity, and in the summertime, we tend to have higher humidity. In higher humidity and in warmer temperatures, the virus lives about a third as long as it does in cooler temperatures with lower humidity. Does that mean that we are going to see the virus go away completely this summer? That part is unknown, but unlikely. We don't think we're going to see it go away, but we will see less length of virulence or activity that could cause harm. The virus can live for differing amounts of time based on what kind of surface it is. Non-porous surfaces such as stainless steel, other metals, plastic, glass. The virus lives for much longer on those surfaces than it does on things like paper and cardboard. When you think about your clothing, it's a much more porous surface than, say, plastic or glass. And the assumption, again, not tested yet, is that the virus would live for shorter periods of time on clothing than it does on non-porous surfaces. The great thing is that the virus cells are covered in a fatty or a lipid layer that responds really well to just ordinary soap. So washing your clothes in the normal way would take care of anything that might have gotten on your clothing. The other question that we might have is about sunlight and how sunlight might affect how long the virus can live. What we know is that we have visible light and we have the light that's outside our visible spectrum, that is UV or ultraviolet light. There are three types of ultraviolet light that we might consider: UVA and UVB, that make it through the ozone layer and do have some effect on bacteria and viruses, and UVC, which is the sort of light you might see in a hospital setting designed to kill germs. Those are the ones that are most likely to kill the coronavirus most effectively. However, exposure to this sort of UV radiation and this sort of light can actually hurt you. It can hurt your eyes and it can hurt your skin, so you should not be using those sorts of lights at home. Leave this to the medical professionals and the healthcare settings to use these tools effectively. All right, next question would be for Professor Okatch, which is, when will we return to normal? And when will social distancing end?
Thank you so much for asking that question. I think my direct and honest response to this question is that really no one knows when social distancing will end, and no one can tell when things will return to normal. And I know that this response is not what people want to hear, and it's very unsatisfying, especially during an age where we have so much information. We've made so many advances in terms of artificial intelligence and mathematical modeling and simulations. But I'd like you to just spend some time, these next few seconds thinking with me about the fact that theoretically, we can have logical principles that can guide the timing of when we return to normal. So firstly, the idea that if for 14 consecutive days we continue to see a decline in the number of cases, then we can begin to feel like, okay, we're addressing this, and because 14 days is the period of quarantine and cases are continuing decreasing, then we're reaching a place where we can reopen the society and end social distancing. The second thing that I want you to think about is that we have this idea that we call the doubling rate or the doubling time. And that is the duration or the number of days that it takes to see the number of cases or the number of hospital admissions or the number of deaths double. So for example, if on this particular day we had only 20 deaths and in 3 days we had 40 deaths, then it means that the doubling time is 3 days. Ideally, we would like the doubling rate to be 10 days for us to feel like we've reached a point within the pandemic where the hospital systems are not going to be overwhelmed. And if that is the case, then we can go back to normal. So both of these things that I'm talking about, the decline in number of cases for 14 consecutive days or a doubling rate of 10 days, actually require social responsibility and personal responsibility from each and every individual. But we know the reality is that human behavior is very unpredictable. So basically what it means is the only way we can tell when social distancing is going to end or when things are going to return to normal depends on how each of us contributes or adheres to the public health preventative measures that have been put into place. Because if we do adhere to that, then we're likely to see social distancing end early or will return to normal earlier. Another thing that I would like us to think about as we wrestle with these questions is this idea of the economic reality. We live in a world right now where millions of people have lost their jobs. And with every additional day of social distancing, small businesses are very highly unlikely going to be able to bounce back. And so what this means is that we've got extremely high numbers of unemployment. And with unemployment comes other health-related outcomes, such as, fewer people with health insurance. We have things like food insecurity, homelessness, poor nutrition. We have mental health issues, domestic violence. And so as we think about when social distancing is going to end, we really have to weigh between these two, the benefits of social distancing versus the pitfalls of having an economic collapse. And so these are things that would have to dictate when we do open. And so really when we end this has to be viewed from both a health and economic perspective. But in summary, to summarize everything I've said, is that no one knows when we will return to normal, and no one can tell when social distancing is going to end.
Thank you so much. Does anyone have anything to add to that? No. Okay. Yes.
I'll just add that I think that the last point that Professor Okach made about the weighing the effects on the economy and damage to the economy also having public health costs is really important. And another consideration is that if people don't trust that they are safe from getting sick, even if we say, oh, let's open the economy now, people might not go back out and start consuming the way they were before. So some people are thinking about these things as opposed, and some people are thinking about them as complementary. So I just sort of wanted to add to what you were saying and say that we can see, some people see strict social distancing as the fastest path back to economic mortality.
Thank you, Professor Marshall. All right. The final question before we move on to recommendations is one that I'll be taking. And someone asked, a few people actually asked, how would accelerated vaccine timelines affect safety and efficacy of those vaccines? First off, we want to talk about what efficacy is, which is basically how well something works in a real world situation. We take it outside of the lab and we put it out into the world and we see how well it works as intended. And basically, the long and the short of it is, we have a number of measures and processes in place that are intended to protect us from unintended harms, unanticipated harms, and to make sure that the vaccines and other medications that we might take actually do the thing that we think they're going to do. To that end, the Food and Drug Administration has divided how vaccines, speaking specifically about vaccines, how they are developed, tested, produced, and regulated out in the world. To begin with, and my guess is that we are probably at the second of these stages right now for many researchers. To begin with, though, we have the exploratory stage where researchers work intensely to try to identify antigens. That is the thing that would fight against the virus and keep us from getting sick. Then we'd move on to the preclinical stage, and that's where we use not humans for testing yet, but small tissue cultures and cell cultures to see if applying the antigen that's developed in the lab would actually keep those cell cultures or tissue cultures from being vulnerable to the virus. If that works, then we have the first sense that this might be a good path to continue on. And we'd move into either 3 or 4 stages of clinical development, which starts very small with small numbers of people. Because remember, we don't know yet exactly what sort of dose is needed or if it's safe or not. So researchers would look at small numbers of people first to look at safety, to make sure that taking in this potential vaccine would actually be safe and not cause harm. And then in later stages, they look at both safety and dose effectiveness at the same time. Are we giving enough to make a difference, to do the thing we mean it to do? That is, protect against coronavirus. In later stages, we then look at scheduling of vaccines. Would we need more than one injection, potentially? And some common side effects. Greater numbers of people become involved in this testing as we learn more. And in stage 3, we refine that information. We learn a lot more about fine-tuning doses, fine-tuning timing, and learning more about some of the common side effects and some more rare side effects that we may not have found with those small numbers that were tested earlier. Stage 4 is a type of testing that's done after a vaccine is released out to the public, in which drug companies, researchers monitor to see if there are any effects once we release this to millions of people. At the end of stage 3, there can be an application placed with the FDA that asks to license this vaccine, this specific product, so that they can go into production and distribution. Once it is produced, it is quality controlled to make sure that it is indeed living up to the standards that were developed early in the lab, and that what we're sending out to the people would be safe. At that point, your medical providers could give you these vaccines. Rushing this process means that we will almost certainly have unintended consequences. We are going to have side effects. We are going to have people become ill, potentially die, have all kinds of effects we do not want to see happen. It also means that perhaps the vaccine wouldn't protect against the virus in the way we think it would. So sticking close to the timeline is probably going to be our safest bet. I know that we are weary of this. I know that we want this to end sooner rather than later. But if we rush it, really bad stuff can happen. We have had poor outcomes in the past from rushing or making errors in any number of these stages, whether it be in exploration, clinical development, manufacturing, or even quality control. So it's staged out this way with the intention of protecting the public's health. Anybody have anything to add to that? Okay.
I mean, it is a long process, right? It's not something that you might look at the 6 different steps or however many steps there, but I think more importantly, it's for us to realize that this can take more than a year to get a vaccine from conception, conceptualizing the idea of one to actually being able to roll one out can take a good number of months.
Absolutely. And even an expedited timeline is probably a year. It's closer to a year and a half, 2 years. Would you say, is that correct?
Yeah, that feels.
Yeah. All right. And we have a number of recommendations that we will provide links to. that give you the opportunity to explore these topics and more, to learn more information. Does anybody want to speak specifically to any of them that they've included?
I just wanted to mention that one of the links is to Professor Allison Buttenheim at Penn, who Professor Okach brought to campus this spring to talk about a different topic, but she has started a group. They call themselves the Nerdy Girls, and it's a group of women who are public health experts, and they have an Instagram and Facebook groups, or whatever Instagram has, called Dear Pandemic. But people who are impressed by Professor Buttenheim when she was here in the large audience might want to check that out in particular.
Absolutely. She does a really great job of humanizing this and making it accessible to everybody. Okay. Anything else from anyone? No? Okay. So thank you all for sticking with us through these explanations. I hope that they're helpful. If you have more questions, you may email any of us, but I will more specifically direct emails to me. I will take one for the team, so to speak. Janine.everett@fnm.edu. Thanks a lot.
Thank you.
Thank you.